Yes, good morning, everyone. Thank you for joining us. We are very excited today for the fourth installment of the New York Communication Disorders Colloquium series. I welcome you on behalf of my co-organizers, Max Freeman, Scott Schrader, and Nikladi Kadyamasuma. Today, I'm going to introduce our moderator for the debate, but before I do that, I'm just going to give an overview of how the event is going to go. So we're going to start with our moderator introducing the motion that will be debated, and then the speakers and the panelists will be introduced. The motion will be presented, and then we will hear 10 minutes on either side of the motion for the motion of the CAPD construct, and then 10 minutes against the motion of the CAPD construct. We will have a poll prior to that, so the audience can determine on which side of the motion they feel before the debate ensues. And then following the presentations on either side, we will have a summary. The moderator will ask questions of the debaters, and we will have a Q&A period from all of you participants. We will have some closing remarks. Each side will get 1 minute to debate, and then we will have a final poll. In the final poll, the audience can decide if they were swayed from their original sentiments regarding the motion, and then we will announce the winner. We're very excited to get started, and so without further ado, I will introduce our esteemed moderator, who is Akshay Maggu of Hofstra University. Dr. Maggu trained as an auditory cognitive neuroscientist from the University of Michigan Medical School and Duke University. Currently at Hofstra University, Dr. Maggu is heading the Auditory Brain and Cognition Lab, where one of his research foci is to understand the neurophysiological basis of auditory processing disorder. I could not imagine a more perfect moderator for this debate, and I am very excited to have him get started. Okay, Dr. Maggu, we are all here to listen.
Thank you, Dr. Rendazzo, for the very kind introduction. And I will get started now. So let me just share my screen real quick. So I did prepare a few slides just to give us a sort of a ramp before we go to the real deal. Listen from our experts. I just wanted to introduce the topic and the motion that we're dealing with right now. So CAPD, the current state and controversies. So what do we know already? There are a few existing CAPD definitions. Asha definition for CAPD is that if there is a person with a deficit in one or more of the following skills, that is auditory discrimination, temporal processing, including pattern recognition, temporal integration, temporal ordering, or a deficit in binaural processing, for example, dichotic listening, localization, lateralization, or speech perception and noise, then the person could be considered as having APD. Now, there's another definition from Jurgen and Music's paper where they say an APD may be broadly classified as a deficit in the processing of information that is specific to the auditory modality. Now, the focus with this definition is on the auditory modality, but what are we doing in order to test APD? That brings us to the first controversy, that is domain/modality specificity in the current testing. So we have a lot of these current behavioral tests that some would believe are not domain or modality specific. That is, they cut across the domains of linguistics or cognition. There's a lot of attention and memory involved. So perhaps some people believe, some researchers believe that this is a point of controversy and these tests are not specific to auditory domain, while the other group of researchers believe that these tests are good enough for testing auditory processing disorder. Another controversy in this field is regarding the comorbidity with other disorders. Now, it's sort of well known that CAPD coexists with other disorders such as developmental language delay, dyslexia, and ADHD. But the question arises, which some researchers like to ask, is that, is this comorbidity real? Or is it due to the confounding nature of the tests or tasks involved in evaluating CAPD? Perhaps is there a test which is more loaded in terms of the memory or needs more attention or needs more language? Is it because of that, or is it real comorbidity? So we have people on either side of the fence. So that becomes a point of controversy. The third controversy, and which is, I believe, has got roots in all other controversies in APD as well, is the need for a gold standard. Some researchers tend to believe that if there is no picture, then it did not happen. The idea is that there should be tangible evidence on whether there is a processing deficit. Can it be measured with, for example, MRI or electrophysiology? Is it visible? While the other group might want to believe that it's more of a psychometric thing. And if you're performing less than 2 SD on 2 or more behavioral tests, or less than 3 SD on 1 or more behavioral tests, then you can be considered as APD. So this also becomes a point of controversy. And by the way, this list is not exhaustive. I just want to introduce the topic and talk about a few. Our experts will definitely touch upon these and many more in details. But what happens with these controversies which people are trying to resolve in the field? What are the recommendations for audiologists and SLPs? What do they do? So we need to know for them that what is and what is not APD, and how to and how not to diagnose APD. And they also want to know, where do we go from here in terms of management? We are not sure about what APD is, or is there a confusion on how to even manage or treat APD, when it comes to that. So with all these issues, some people have rightly pointed out that APD as a subfield and as a subtopic in audiology could be considered as a Pandora's box. And it's no surprise that this kind of debate has not taken place for so long, and it has been due for like 3 or 4 decades, I believe, because people didn't want to open this Pandora's box. And I'm really thankful to our expert speakers who have agreed to be a part of this debate and who would help us and try uncover and unlid this Pandora box just a little. With this, I introduce to you the motion of today's debate. It is, the CAPD construct possesses the intelligibility necessary for diagnosis and treatment. And at this juncture, I would ask our audience to actually go for the poll. Let me just launch the poll real quick. So I'm going to launch the poll, and audience could actually vote. Okay. So the poll is on. And now I'll go ahead and introduce our experts, eminent scholars who have agreed to be a part of this debate. We have Dr. David Moore from University of Cincinnati and Dr. Asha Yathiraj from University of Mysore, who are going to speak for the motion. We have Dr. Andy Vermiglio and Dr. Wayne Wilson, who are going to speak against the motion. So Dr. David Moore is the Director of Communication Sciences Research Center at Cincinnati Children's Hospital. Dr. Moore's research interests are many, but some of them include development of listening skills and their neural mechanisms in children. Dr. Moore also studies the effect of impoverished and enriched communication on the developing human brain. Dr. Moore has worked at several prestigious institutions, including University of Oxford and University of Manchester. In 2015, he received the Career Award in Hearing or Balance of the American Academy of Audiology. In 2016, Dr. Moore delivered the T.S. Littler Lecture to the British Society of Audiology. We also have Dr. Asha Yathiraj, who is a professor of audiology at the University of Mysore. Dr. Yathiraj's interests include CAPD and cochlear implants. She has developed several tests for CAPD and has authored over 150 publications. Dr. Yathiraj also served as a WHO fellow at the Central Institute for the Deaf. She served as the president of the Indian Speech and Hearing Association, and she also received very prestigious Professor Padma Shri S. Kameshwaran Oration Award in 2007. we have with us Dr. Andrew Vermiglio, who is assistant professor at East Carolina University, and where he's the director of the Speech Perception Lab. Dr. Vermiglio's interests include speech recognition and noise, diagnostic accuracy studies, and to research the controversial auditory processing disorder construct. He was a content matter expert for the Asha practice portal on CAPD. Prior to audiology, Dr. Vermiglio served in the US Navy and US Army. Last but not the least, we also have Dr. Wayne Wilson, who is an associate professor and the head of audiology at the University of Queensland. Dr. Wilson's research interests include auditory processing and auditory processing disorder. Dr. Wilson has obtained over 35 grants and published over 100 research papers. He was awarded a certificate of outstanding service by Audiology Australia for his national and international research, teaching, and service in the fields of AP and APD. Now, with that, without further ado, I would like to request Dr. Dave Moore to please share his screen and start with his advocacy. Oh, I don't know if Melissa was supposed to do that. Sorry.
And speakers for the motion of CAPD, you now have 10 minutes to argue your side.
I just need to. Okay, do we have my screen there?
Not yet, Dave. Yes, now we can see it.
Okay, fantastic. So thank you very much for inviting me to participate in this debate. And I would like to start by introducing the concept of listening difficulties. I think everybody knows intuitively what a listening difficulty is. It's a self-reported problem with listening. And we all know, I also think, that hearing ability is defined classically by the clinical audiogram. And over the last 10 years in particular, there's been increasing agreement that the audiogram does not really describe a lot of very important aspects of listening. And in particular, it doesn't seem to describe very well problems that people most commonly report when they see an audiologist, which is difficulty hearing speech in challenging environments. I'll come back to that in a minute, but I think the thing I'd really like to hit home with here is that listening difficulties affect people of all ages, children as well as adults. And a recent study by Brent Edwards has suggested that in the United States, among adults, there are 40 million people who have listening difficulties associated with an audiological hearing loss, but another 40 million who have listening difficulties that are not described by a problem with their audiograms. So in other words, we've got a massive population here who are currently underserved by current audiological practice. So moving on to my next point, APD is historically a tortured subject, and people have argued one way and another about the use of the term APD, and even the topic of this debate calls to, I think, the notion of a construct of APD. But I'd like to present a different perspective on this, which is that APD is a name that historically has been used for listening difficulties. If you consider the literature in this field, the typical presentation is somebody coming to an audiologist. They say they have listening difficulties. The audiologist tests their ability to hear, finds that by their test, there isn't a problem there. And so they say, well, if they came to an audiologist, they've got listening difficulties. We don't find a difficulty with processing in the ear. So therefore, the problem must be in the central auditory system. And traditionally, the central auditory system has been used to define the part of the brain going from the cochlea up to the auditory cortex, sometimes just the primary auditory cortex. And so they then developed a whole lot of tests, some of which may be testing that pathway. I suggest most of them do not. Most of them test a much broader range of abilities than what's happening within the central auditory system. And then they said, well, if you fail these tests, you've got APD. Well, the problem with that is that it assumes that those tests are specific to the central auditory system. And it turns out that it's incredibly difficult to devise a test that is specific to the central auditory system, because the simple reason is that the central auditory system, and indeed the peripheral auditory system, need the auditory cortex and indeed areas in the cortex beyond the auditory cortex in order to function. If you think about it, when you do an audiogram, you're asked to push a button when you hear a tone. You have to understand that instruction, you have to know what to push, and most importantly of all, that auditory information you hear has to go right up to the cortex and activate the regions of the cortex which have been implicated in consciousness, which according to current diktat, seems to be somewhere around the parietal cortex of the brain, but certainly well removed from the auditory cortex. So even that simple act involves something that goes way beyond the cochlea and indeed the auditory system in general. So the question then is, can we define what's going wrong in the central auditory nervous system? Well, I've devoted about 20 years of my life trying to address that question. And we believe, and when I say we, I should mention Harvey Dillon here, who is my partner in crime in this area. We believe that it is possible to do some auditory testing which is specific to the central auditory system by using a subtraction or a derived approach, which is a pretty complex concept that I don't want to go down now, but essentially it's doing two tests of the same auditory function and subtracting them on the premise that all of the cognitive issues involved in those tests are going to be common to the two tests. And what you have left in the difference between the two could be conceived as a pure auditory problem of the central auditory system. And the upshot of all that is that when you do those subtraction tests, you typically find very little role of the central auditory system in any hearing task. And there have been many tested. So if it's not happening in the central auditory system, where is it happening? And for my next point, APD is a speech hearing problem. As I mentioned at the outset, if you go back to the literature, you'll find that the most common complaint that people have, especially adults who are able to be a bit more introspective about these things than children, they say that the problem is hearing speech in challenging environments. So the earliest parts of a distinctly speech coding pathway are occurring actually beyond the primary auditory cortex and out into the temporal lobe of the brain. And at this level, we find that people are, with various methods, both physiological, magnetic stimulation and others, we find that those parts of the brain in the temporal cortex are those that are really mostly involved in coding from auditory stimuli into some sort of speech construct. And beyond that, speech obviously gets more complex as you go more towards the front of the brain, and we start recruiting and getting more and more involvement of other areas within the brain. So my next point is that APD problems occur mostly in the cortex. That's I think, a simple summary of all the research we've been doing over all these years. So we found recently, using functional magnetic resonance imaging, that there are very specific pathways that seem to be disrupted in children who have a listening difficulty but normal audiograms. And this is my final point, which is a very evidence-based point, and please forgive me for not showing the slide on this. It's unpublished data, but we have presented it at several meetings. If we look at resting state functional connectivity in the brain, which is the ability of different parts of the brain to synchronize their activity, and which is used generally throughout neuroscience as a method for looking at how different systems of the brain operate. And we look at the speech coding network, what we find is that kids with listening difficulties have a hugely reduced functional connectivity in the speech coding network. However, if what we did was construct another series of networks in the cortex, which are
1 minute warning.
specific for other aspects of hearing, but not for speech. And I'm talking now about the things auditory scientists use, like tones and clicks and perhaps music, environmental sounds, all of these things. And in that respect, the children with listening difficulties had no problem whatsoever in their functional connectivity. So I'd like to rest my advocacy of the APD construct by saying that we now have, I think, very tangible mechanistic evidence that APD is a speech processing problem. And in that sense, to address one of the questions that Akshay mentioned at the beginning, that the comorbidity is total, that what we're looking at with APD is really a language and speech processing problem.
All right, next speaker has 10 minutes.
Okay, thank you very much. And thank you, Dave, for that great talk. So I'm going to be arguing against the motion. Everybody can hear me, right? I'm good to go? Okay, thanks. So I'm arguing against the motion. In a diagnostic system, a gold or reference standard test is used in order to determine the accuracy or validity of the test under evaluation. We have an index test, which is the test under evaluation. We have the target condition or target disorder and the gold standard. And the gold standard test allows us to determine the accuracy of the index test results. The index test gives us the positive and negative test results. We compare those test results to the results of the reference standard, and in this way we can determine if the index test results are true or false. And sensitivity, as you know, is
Andy.
Yes.
Yeah, I'm so sorry to interrupt. I think we're still seeing Dave's slides. Dave, can you stop sharing your screen? I apologize.
That's okay.
Yes, there we go. Now we see Andy's slides.
All right. Can I get a start over on the time?
Yeah. Go ahead, start over. Sorry about that.
Yeah.
Okay. All right. Thank you. So I'm Andrew Vermiglio, AUD, not PhD, just a correction there. And I'm arguing against the motion. Okay, one more time. In a diagnostic system, a gold or reference standard test is used in order to determine the accuracy or validity of the test under evaluation. We take our test and we're trying to ask the question, is this test accurate in detecting the presence and absence of a disorder? And in order to do that, we need a gold or reference standard test. So we'll take the results of the index test, compare it to the results of the reference standard, and answer the question, are the results from the index test true or false? And as you know, sensitivity represents the percentage of true positive results, and specificity represents the percentage of true negative results. Here's the APD construct. According to AAA 2010, behavioral tests, which are sensitive to the presence of confirmed lesions of the central auditory nervous system, may be used to diagnose a CAPD in the absence of a CANS lesion. AAA 2010 also states, while recognizing the value of tests not standardized on individuals with documented CANS lesions, it is clear that test efficiency measured on subjects with well-defined lesions of the CANS provides an important guide for establishing the validity of central auditory diagnostic tests. So here's the presumption from AAA. Tests with known diagnostic efficiency for the detection of a lesion of the cans may also be used to detect a CAPD. Unfortunately, there is no reference standard or gold standard test to test this presumption. Let me share this with you. A legitimate disorder is one that possesses the intelligibility, that is clarity necessary for diagnosis and intervention. Another name for a legitimate disorder is a clinical entity. And in 2014, we came out with a paper describing the Sydenham-Gutentag criteria for the legitimacy of various disorders. And according to the Sydenham-Gutentag criteria, a legitimate disorder, also called a clinical entity, has an unambiguous definition. It represents a homogeneous patient group. It represents a perceived limitation for the patient. It facilitates diagnosis and it facilitates intervention. And I compared the standard or these criteria to an auditory processing disorder, the constructive APD, in this article, which you can read all about that. Let's take these one by one. One, CAPD lacks an unambiguous definition. And according to Dr. James Jerger, there seem to be more descriptions of APD than there are children who actually have it. Two, CAPD represents a heterogeneous patient group. There is no standardized test protocol for CAPD. And some audiologists may use as few as 3 tests, and others may include several tests administered over 2 days. According to AAA 2010, a fail on 2 behavioral tests indicates an APD diagnosis. When using a test battery with 22 tests, let's say, it is possible to have 462 patients with 462 different types of APD. Clearly, APD represents a heterogeneous group of patients. 3, CAPD may or may not represent a limitation for the patient. According to Dillon and colleagues, they question the relationship between CAPD test results and a problem in real life for the patient. The authors wrote that a fail does not necessarily indicate that the patient actually has a problem. And Shermack and colleagues stated, since central auditory measures show a significant degree of construct validity in neurological models of CAPD, this lack of agreement between observer report and performance-based measures indicates that subjective report of listening difficulties is not predictive of true CAPD, which is very interesting. And this goes against the Sydenham-Gutentag criteria for the legitimacy of a disorder. 4, CAPD does not facilitate, that is, make easy diagnosis. There are multiple criteria for the diagnosis of a CAPD. Unfortunately, in the absence of a gold or reference standard test, there is no way to determine the validity or diagnostic accuracy of any of the criteria. This is a very interesting study by Dr. Wilson and Arnott from 2013. They took 4 different behavioral tests and administered these tests to 150 children. And they used diagnostic criteria from nine different sources. And using the diagnostic criteria from consistent with Asha 2005, they found that 96% of these kids had the diagnosis of APD, where when they used the criteria from Dr. Bellis, only 7.3% of the kids had were diagnosed with an APD. So which is it? Is it the 96% of these children have an APD, or is it the 7.3? In the absence of a gold or reference standard, there is no way to determine if a positive CAPD test or test battery result is true or false. That is, in the absence of a CANS lesion. In other words, there is no way to determine if the diagnosis itself is valid. According to Aetna, there is no gold standard investigation for APD and no standardized criteria for diagnosis. According to Asha, because of the variability in the nature of the profiles of CAPD, there exists no absolute gold standard for deriving sensitivity and specificity data for tests of central auditory dysfunction. According to Shermack and colleagues, while there might not be a universally accepted gold standard, we have a considerable body of research demonstrating the efficiency of individual central auditory tests on individuals with confirmed CANS lesions. And very recently, Shao et al. Noted, unfortunately, all of us doing work in this area have difficulty finding an ideal reference that is gold standard, and therefore finding rock solid sensitivity numbers remains elusive. So one suggested solution is to simply take some version of the APD test battery and say, you know what, we're going to use that as the gold standard. So then they shifted over here to the gold standard side. However, this begs the question, why is it called a gold standard? And where's the diagnostic accuracy study conducted to demonstrate the diagnostic efficiency of that particular group of tests to be used as a gold standard? And in some of these studies, you'll find that the index test or the test under evaluation is actually part of the reference standard test battery. And according to the starred statement, the reference standard should be an independent verification of the index test result. So what we have is an untested presumption from AAA that tests with known diagnostic efficiency for the detection of a lesion of the CANS may be used to detect a CAPD. It's untested because we lack a gold or reference standard in order to test this presumption. 5, CAPD does not facilitate intervention. Fay et al., in a review of the literature and a study commissioned by Asha, concluded that the evidence base is too small and weak to provide clear guidance to speech language pathologists faced with treating children with diagnosed CAPD. The CAPD construct is based on the untested presumption that tests able to detect the presence and absence of a CANS lesion may be used to diagnose a CAPD in the absence of this lesion. The lack of a gold standard for CAPD is not trivial. It results in the inability to verify the CAPD test results and the very presence of the disorder. There is no way to determine if a diagnosis of CAPD in the absence of a CANS lesion is true or false. This argument supports a no vote on the motion. And I'd like to, thanks for your kind attention. I really appreciate it. Okay, I got just less than 1 minute. Let me refer you to this other information. This will be on a PDF that will be made available to you. And you can read about the information on the clinical entity, diagnostic accuracy, and then I also make an argument for using self-report from the research subjects as a reference standard in audiology to move forward with this issue of treating individuals with listening difficulties in the presence of normal pure tone thresholds. Thank you.
All right, the next speaker for the construct has 10 minutes.
This bar is preventing me from, okay. I'm sorry. Okay. Let me start by thanking Akshay and all his colleagues for giving me this opportunity. And I'm going to be talking about for the motion about the topic, CAPD construct possesses the intelligibility necessary for diagnosis and treatment. And I am going to use these guidelines and the construct within them to say that I am supporting the motion. Besides these three, that is the New Zealand guidelines, the AAA guidelines, and the Asha guidelines, I'm also going to be using some of the British guidelines. And everything that I talk about today is going to be supported with literature or empirical evidence. So to support this motion, I'm going to be talking about the terminology. Should individuals be diagnosed as having APD? And I will definitely talk about the gold standard part of it, the modality specificity of APD, does cognition affect evaluation of auditory processing, and whether it is a top-down or a bottom-up process. So let's start out with the terminology. And I support the term auditory processing disorder. And this is mentioned in most of the guidelines given. And Asha 2005 states that the term APD and CAPD can be used synonymously. And I think also it's an all-encompassing term when you use the term APD. Now, this is the part that I'm going to be dwelling on quite a bit. Should an individual be diagnosed as having APD? And is it necessary to have a cutoff criteria to categorize an individual as having APD? Before I start off talking about it, and as you see a big yes written over there, and the whole issue comes in about the gold standard. Let me tell you how I have gone about constructing my own gold standard. So we have actually evaluated a group of children over here in our own areas and tried to see which of the processes are going to be affected. We've got normative data from them. So we have come up with our own gold standard. So we've taken different processes that are defined in the different guidelines that have been given. And we try to make sure that it covers different kinds of processes, but the ones that occur more often, which are more deviant in our population. So yes, we can have a cutoff criteria, and the classification of a condition is required to make a cutoff criteria, and it's being used for other conditions. When you talk about, let's say, somebody with a peripheral hearing loss, we do have a classification, and we have been using this classification. Yes, you may say that's a gold standard, and we can come up with our own gold standard. So we have to work around it and come up with a gold standard the way I have done in Mysore over here. And all of my literature that I have has got this gold standard. So this has been said right in 1981 that you need a classification for medical legal purposes as well as for research. And an example of a situation where a specific diagnosis and a classification is useful is when APD was being projected in a court case. So you have your own USA-based court case where you have EM versus the Pajaro Valley Unified School District case. And it was because of the diagnosis that the client got his benefit. And I have my own set of articles, which I have come up very similar to what is there in AAA, which talks about the 2 SD versus 3 SD criteria. And we have come up with the 1 SD versus 2 SD criteria. And when this was published in 2018, it was criticized by North and Fox, and they criticized the entire article, saying that we should not be using a diagnostic criteria, and you should go by symptomatic kind of a criteria. Now, if you went about by using just a symptomatic criteria, it's going to be extremely difficult to differentially diagnose, because you have a lot of overlapping symptoms with those with the delayed language development, autism, maybe ADHD. And so all these conditions, including LD, might have overlapping symptoms. Now, why do we need to differentially diagnose them? Because the treatment procedure or the management procedure for these are going to be different. You can't use the management procedure for ADHD and use that with a child who has APD. So you need to differentiate these different conditions. And now they have overlapping symptoms. So unless you use a test and then say, okay, this is definitely a child who has a problem with the processing, auditory processing, versus not having a problem with auditory processing. So if you do not evaluate that, you will not get this information. So my contention is saying you have to differentially diagnose. So you start off with using a screening test or a screening checklist. And I have been using this for years. And we have got a set of screening tests and screening checklists. And when the symptoms, there are times when we do find that there is overlapping between a child who may be having ADHD and maybe APD. And that's when the objective tests come into play. So before you actually run in and say that the tests for APD need to be done, screen out and rule out these other conditions. So if you have to, you could be doing a contralateral suppression of OE, you do an objective set of tests, and then make sure that you are sure that the person has a processing problem. We all know that if you have any additional other problem, it is going to be confounding the test results. So rule out these problems first. So and the next thing is with reference to saying, is it modality specific or not? And I say definitely it is an auditory processing problem. The first definition itself, I said auditory. And so I'm supporting the motion saying that it is definitely auditory. And this is again from my empirical evidence that says that auditory signal is significantly processed from an analogous visual signal. And this is based on data of 30 typically developing children, where we evaluated separation closure, integration, duration, pattern perception, as well as memory, 2 different articles. And we found significantly different information. Then when we did the similar kind of test on children with LD, also we find differences over there. And next point, does cognition affect evaluation of auditory processing? There is a definite link between the two. And you see here Maggu's articles coming in over here. So there is a link between speech perception and noise and memory. And this has been demonstrated in one of our articles. This was not what we were looking for, but it came up over there. Then we found that temporal patterning training also brought about an improvement in duration pattern, which we were working on, as well as auditory memory. Then temporal resolution training in older adults also brought about improvement in auditory memory. This along with other processing. So showing that there is a link between memory, that is cognitive skills, and your auditory processing. But now look at what the New Zealand guideline says. For individuals with average abilities, the cognitive and other factors shall not distort an APD test results because the norms are derived on an average population. Cognitive abilities outside the normal range may affect it. So that's the reason we are running all these tests to make sure that it doesn't affect it. And are we more in for a bottom-up or a top-down approach? And I'm definitely more for a bottom-up approach, because when we manipulate the acoustical patterns and we evaluate them, and we see that there is a definite improvement over there. However, I kept saying that there is a definite link between the cognition and the bottom-up approach. So there definitely, you could be using a meta-linguistic or a metacognitive set of strategies. So I want to conclude that, and I hope that I've convinced a lot of you that the APD construct does possess the intelligibility necessary for the diagnosis and management of APD, because we are going to be doing deficit-specific management for those with APD. Thank you.
Thank you. The next speaker against the motion has 10 minutes.
Thank you. Just allow me a moment to set up my presentation. May I confirm that everybody can see a PowerPoint presentation? Lovely, thank you. My argument against the motion will be a little more philosophical than those of the previous speakers. I'm going to focus on constructs and the problems with our CAPD construct that affect its intelligibility. In the philosophy of science, a construct is an explanatory variable that is not directly observable. An example from psychology is intelligence. We can't directly observe intelligence. What we can directly observe is behaviors and performance on tests. We then use those observations to make inferences about a person's intelligence. This is shown on the left of this slide using the notation of structural equation modeling. The unobservable construct of intelligence is in the circle. The observable behaviors and test results are in the squares. The numbers shown are just random examples of how the strength by which constructs might be inferred through observations. In audiology, we have used the construct of CAPD in a similar way. We can't directly observe CAPD, so we observe a person's auditory behaviors and performance on auditory tests to infer the presence or absence of CAPD. But I'm going to argue that we're not doing it right. Let me explain. Let's take the Asha and AAA definition of CAPD shown here on the right to see if we can determine which part of the definition is the construct and which part is the observations we will use to infer the presence of the construct. If we look closely at the definition, it appears to define the CAPD construct as difficulties in the perceptual processing of auditory information in the CNS, and the observations as poor performance in one or more of the following skills. It also seems to separate the construct of CAPD from the constructs of higher order cognitive, communicative, and/or language-related functions. That seems intelligible, doesn't it? We can't directly observe the CAPD construct shown in red. We can directly observe poor performance on the skills shown in green, and we want to separate CAPD from other higher order cognitive, communicative, and language-related constructs. So doesn't that mean the CAPD construct does possess the intelligibility necessary for diagnosis and treatment? I'm going to argue it doesn't for two reasons. The first is the assumption that poor performance on tests of CAP can be used to infer the presence of CAPD. Let's consider an example from Cameron and colleagues' work on developing a new dichotic digits test called the dichotic digits difference test. By testing both children and adults on both dichotic and diotic listening, and considering both absolute scores and difference scores, Cameron and colleagues concluded that 61% of the variance in free recall dichotic listening was accounted for by non-dichotic factors, such as attention and memory. In other words, poor performance on dichotic digits was okay for inferring the presence of CAPD, but it was better for inferring the presence of poor attention and memory. Another example of this could be low-pass filtered speech, which might be okay for inferring the presence of CAPD, but could be better for inferring the presence of a language disorder. The second reason why the CAPD construct might not possess the intelligibility necessary for diagnosis and treatment is the possibility that our tests of CAP may represent constructs in and of themselves. Let's consider an example from Anderson and colleagues and their investigation of speech and noise ability in 120 adults. Rather than considering speech and noise as the observation used to infer CAPD, as shown on the left of the figure, Anderson and colleagues considered speech and noise as a construct, shown in the center of the figure on the right, with the speech and noise construct inferred from performance on the QuickSyn, the WIN, and the HINT tests. By considering speech and noise as a construct, Anderson was able to compare speech and noise to other constructs to see their influences. To discover that speech and noise as a construct was influenced by cognition, measured by working memory, short-term memory, and auditory attention. It was influenced by central processing, measured by auditory evoked potentials. And interestingly, it was influenced by life experiences, as measured by socioeconomic status, physical activity, and intellectual engagement. Here we can see something that we had been considering as the observable variable, speech and noise, may be better considered as a construct in and of itself. What these two arguments against the motion suggest is the construct of CAPD isn't what's shown here on the left, a single construct easily inferred from a few observable behaviors and/or test results. Instead, the construct of CAPD is probably more like what is shown on the right, perhaps multiple constructs, each inferred from multiple observable behaviors and/or test results. While I have argued that the construct of CAPD isn't intelligible, I would also like to argue that the construct of CAPD remains extremely useful as we continue our efforts to better understand the full spectrum of human auditory behavior. I do not think we should abandon the construct of CAPD. Instead, I think we should redouble our efforts to test the CAPD construct in ways that better consider its complexity and its relationships with other constructs. Some of this complexity could be better understood by statistically modeling CAPD constructs in a manner that could allow us to determine what proportion of eliciting behavior is explained by CAPD and what proportions are explained by other constructs, such as memory and attention, which is actually a point Dave touched on in his presentation and something being argued by Harvey Dillon and Sharon Cameron. Finally, we should note that we're certainly not alone in our efforts to improve our understanding of constructs such as CAPD. If we return to our simple construct of intelligence, where I started my talk, shown here on the left, we can see that over 100 years of research has led to great improvements in that construct, leading to things like the Cattell, Horn, and Carroll theory of intelligence shown here on the right, a much more fleshed out, much more detailed explanation of the construct of intelligence. And interestingly, if you look closely at that model, you'll see it contains auditory processing. If psychology can do this for the construct of intelligence, then we can do the same for the construct of CAPD. Thank you.
Thank you. So now this portion of the debate is for the moderator to discuss a Q&A with the panelists. Following that, we will have an audience Q&A. Please feel free to submit your questions in the chat. Thank you.
Thanks, Dr.
We have 10 minutes for this discussion.
And Dr. Freeman for keeping the time. Thank you all speakers, and this was really a delight listening to all different views. To all the viewers, the attendees who have joined us later, after 10 a.m. Eastern, Dr. Smoor and Dr. Yathiraj talked for the motion, and Dr. Vermiglio and Dr. Wilson talked against the motion. Dr. Moore's talk had a new terminology, which is listening difficulties, and the proposal was that probably APD is a speech processing problem, and and we can have MRI evidence to support that. They have unpublished data, which hopefully gets published soon. Dr. Vermiglio's talk was very impressive in terms of letting us know what's wrong with the field, in terms of there's a need for the gold standard, the construct is real or not APD, and what needs to be done. Dr. Yathiraj's talk was in the area of how to diagnose APD and what should we do in terms of the treatment of APD. And she also talked about multimodal testing that they had done. And so I have a follow-up question on that, and I'll come back to that again. Dr. Wilson's talk had a lot of structural equation modeling. With that, what we got to know that there is a long way to go. Although we think this debate was categorical yes or no, but I think there's a continua on where people could lie, if that APD, it does not exist, or it exists, or it's a yay, it's a nay. Some people are in between, and that's totally okay, I believe. As a field, moving forward, we have to be in the continua. The whole idea of this debate was to get the people to talk about it openly with an open mind. And so I thank all speakers for that. So I have a question for Dr. David Moore for my own understanding, and that would be helpful for the attendees as well. Dr. Moore, you talked about listening difficulties, and it's probably being a speech processing problem. So I guess the question, the more intuitive question from the point of view of a clinician would be, where do we go, or how should we go about the diagnosis and even management of listening difficulties?
So I think that, this whole debate has been fascinating in terms of which extend way beyond the APD field. I think what we're looking at here is questions about how audiologists look at hearing and listening in general. And I would argue that in addition to having an audiometry gold standard, we should also have a speech in noise gold standard and a self-report gold standard. And I would argue that the area of listening difficulties comes under the self-report rubric. I think this is an area that has been really neglected in audiology, and which we now have an opportunity to grasp. And I think that the APD construct actually fits really neatly into that area, because what we're asking about is, what sort of problems do you have in your everyday life? Or we're asking parents to describe what sort of problems their children have. One element that was missing from my talk, which I could add now, is that we had as our independent variable, our sort of central platform, a questionnaire which was given to caregivers about their children's auditory behavior and associated forms of behavior. And we related everything else to that. So even though we were able to, in the end, home in on the particular MRI and supporting behavioral evidence, it was really based on the idea that the parents know best what their children are hearing, and similarly, adults know best what their own difficulties are.
Right. That's great. Thank you, Dr. Moore. A follow-up question would be, we did talk, you in your talk mentioned that it's probably more of a cortical phenomena, but do you also think that subcortical areas, for example, auditory brainstem, could have a role? And does auditory electrophysiology has a future in quote unquote APD? Absolutely.
In fact, part of our research has been focusing on the auditory brainstem. And surprisingly, we have evidence, which is also currently unpublished, but we're getting there with it, showing that aspects of the later waves of the auditory brainstem response are actually amplified in the children who had listening difficulties relative to the typically developing children. And our interpretation of this is, as we all know, the efferent system from the cortex is actually numerically stronger than the afferent system. In other words, there are more fibers coming out of the cortex going down into the brainstem than there are going up into it from the auditory system. And that must be doing something. Yeah. And it seems like that's probably modulating these brainstem factors. So we get this very surprising result for us that these brain potentials are actually stronger, and also supporting evidence also from middle ear muscle reflexes, which seem to be showing the same sort of phenomenon. So I would argue that that we do have some evidence for changes in the brainstem, but we believe that these are efferent with origins in the cortex.
Perfect. Thank you, Dr. Moore. Dr. Vermiglio, again, thanks for the wonderful talk. And in your talk, we learned about what are the problems with APD and the subfield as an overall, Dr. Vermiglio. But I guess my question, and more intuitive one, would be more generic question would be, what do we do now? Where do we go from here? You did mention a reference of Aetna, and that the insurance also does not cover a lot of time. There are issues in covering APD. So Dr. Vermiglio, what do you have to say on where are we going as a subfield?
Thanks for that wonderful question, Akshay. So the way I look at it is the CAPD construct, the diagnosis of CAPD, according to the construct from AAA, must be disambiguated after the diagnosis. So we have the diagnosis, we're not really sure what it is. So now we have to disambiguate it, right? So we have to figure out exactly what's going on. So I think it's upside down. I think we have to do the disambiguation at the conceptualization of the disorders. So if we're talking about a speech and noise disorder, auditory working memory disorder, possibly a dichotic listening disorder, etc., we could bust up APD into distinct clinical entities. Once we have a clear path or clear understanding of what the specific disorders are, then we open ourselves up for procuring reasonable reference standards. And we've made the argument that for a speech and noise disorder, we could actually use subject report of listening difficulties as the reference standard. And we've conducted this study. We had the folks with the self-reported listening disorder, that was the disordered groups. I mean, speech and noise disorder. Folks who said they don't have that disorder, they're in the control group. And then we could go ahead and determine the diagnostic accuracy. We determined the diagnostic accuracy of the hint that way. We recently published a paper on the AZ Bio doing a similar thing, but instead of asking about listening difficulties in the real world, we put them in the laboratory. So everybody had the same listening environment. And they told us if they could hear the sentences or not. Right. So I think this is a path forward. Self-report has also been used on studies with tinnitus. Who gets in the tinnitus group? Well, they tell us that they have tinnitus. Who gets in the group with pain? Well, the patients tell us that they have pain. So there needs to be a connection between the self-perception of our patients and the disorder, the construct of the disorder, and the testing. So I think that's the path forward.
Perfect. Thank you, Dr. Vermiglio. I'll move on to Dr. Asha Yathiraj. Dr. Yathiraj, thanks for the very interesting talk. And you talked about a lot of your studies, which are focused on auditory processing disorder. I guess a lot of us would have discussion, Dr. Yathiraj, that how would you recommend that we go forward, or what do you think should be the diagnostics, in future? Should we go for a multimodal approach, testing different modalities at once, or a multi-domain approach, and then try to disambiguate and figure out if the disorder is in auditory and not in visual, and so on? What do you think?
There's 1 minute.
If you look at those with the listening difficulties, with learning disabilities, you would see that some of them have more of a visual-based problem and some of them have more of an auditory-based problem. And you have to differentiate because the management is going to be different depending on whether they have more visual or auditory-based. And we've now developed analogous material. We actually have one more part which I didn't talk about, and that is the audiovisual integration part of it. So we have a group of children who just could do the auditory alone, they could do the visual alone, but when you gave the auditory and visual together, they had a lot more difficulty. You would think that copying from a board is an easy task, but these children have to read, and that reading part is an auditory skill. And then trying to write it down, there's a visual skill that is coming in. So that auditory visual integration becomes so much more difficult. So we need to go beyond and think of that aspect also. On not just an integration problem within the auditory signals, but an integration of an auditory and a visual. And I'm saying each one of these modalities are independent and they also have to be integrated to be able to perceive over there. And I'm not talking about the McGurk phenomenon at all. So yes, definitely there's room for us to look forward to doing something more in a different aspect to see that whether we can help children in a different way.
Thank you, Dr. Yathiraj. Can I have a quick comment from Dr. Wilson on what's the way forward, Dr. Wilson, in terms of should we use speech and noise as a construct? Is that the rock star in the center with everything else on the sides of APD?
Quickly, one point I'd like to make is the difference between valid constructs and useful constructs. And whilst there's a lot of argument to be had and being had amongst academics and researchers around the validity of a lot of these constructs, that's good discussion. It's pushing the field forward. It's improving our understanding, but there is still great opportunity for useful constructs. And one of the simplest potentially useful constructs is to assess the skills, identify what skills are strong, identify what skills are weak, and do something about that. Where you identify the weak skills, be that speech and noise, be that dichotic listening, be that temporal patterning, then address that with therapy for listening and noise, therapy for dichotic listening, therapy for temporal patterning. Perhaps removing the whole argument of the validity of the construct, the arguments around definitions, and getting very practical. What are the child's strengths and weaknesses? Do something about it.
Great, thank you. Thank you, Dr. Wilson.
Okay, we have about 8 minutes for Q&A. I think we're gonna start with the chat.
Okay, right, so there's a question from Dr. Larry Medversky on, I think you all can read that. The question is, does speech and noise itself serve as a diagnostic criteria? Dr. Medversky feels it only serves as a degree of difficulty, be it monaural speech and noise, binaural separation, etc. What does the panel feel about it, about the speech and noise measure?
So I'm sorry. So Dr. Medversky, what did he say about the speech and noise? Is that a disorder or a symptom? What was
They
the
say
question?
that speech and noise does not itself serve as a diagnostic criteria, but only as a degree of difficulty. So it's more of sort of symptom, but not on its own. It does not stand as a diagnostic criteria.
Oh, okay. So we've made the argument that a speech recognition and noise disorder is a legitimate entity, clinical entity, using the Sydenham-Gutentag criteria. So it meets all the criterion in that list of the Sydenham-Gutentag criteria. And because it does that, we can procure a reference standard to determine the diagnostic accuracy of the speech and noise test. And we've done this in a couple of studies. And then once you find the test that has the greatest diagnostic accuracy for speech recognition and noise disorder, then you could use that test as a gold standard. So that's how it does. That's a progression that we see, for example, with the MRI. Initially, the MRI was the index test, the test under evaluation. When they found, look, the diagnostic accuracy for that test is pretty good. Now let's bring it over here on this side and call that the gold standard or reference standard test. So I think speech and noise is a disorder. Patients come to the hospital with speech and noise complaints. When I worked at the VA hospital, this is very, very common for young people coming back from military service.
So Dr. Medversky is raising a hand. Perhaps we should, please unmute yourself, sir.
Yeah, oh, I did. Thank you. The reason why I posed that question is that a person can break down in noise for many different reasons. You can have hearing loss above 8,000 and nobody measures it, but that could be a reason. You can be a bilingual, a sequential bilingual, do fine and quiet, but break down and have no processing issues. You can have difficulty in how you organize your lexicon. You can have attentional issues. There are many, many reasons. So speech and noise by itself, yes, you can determine. And first of all, speech and noise is very different whether you do it monaural testing or binaural separation, very different processes. So yes, you can have difficulty, but it cannot tell you what is the underlying reasons for that difficulty. And therefore, in terms of intervention, yes, they can all benefit from a remote mic. But if you want to do specific therapy, you've got to know what the underlying difficulty, because I'm not going to do the same type of therapy for someone who has hearing loss above 8K versus someone who's a sequential bilingual who doesn't have the brain organized for the phonemes or lexicon. So that's why I'm saying it's useful as a construct for difficulty, but by itself is not a diagnostic criteria to know as to what the underlying difficulty is. Sorry. Does that make sense?
Yes, thank you very much for that. So that's a great comment, and it gets at the idea of the categorization of diseases. So there's a field called nosology, which gets to your point where you're looking at the causes of the disorders. There's also another area called nosography that doesn't pay attention to the etiology, right? It's just, this is the disorder, how can we treat this? So we could argue that an FM system or any system to improve the signal to noise ratio is going to help somebody that has signal to noise difficulties, regardless of the problem. So it's two different approaches, nosology versus nosography. But thanks for the great question.
Okay, so thank you guys. There's another question from Ashley Flaggy. The question is, do you think APD, given the heterogeneity, could be actually a continuum or a spectrum? For example, like autism spectrum disorder or auditory neuropathy spectrum disorder. Could it have a spectrum of its own? What does the panel think?
I would very much say yes to oh, sorry, Asha, you go first.
No, I mean, Dr. Wilson.
Okay.
Asha, it's right.
Okay, I would say no to it. I would say because I'm going more from the management technique rather than with reference to the actual test. And I totally agree with Dr. Vermiglio, who says that there are so many different groups that might be having a similar problem. For instance, if you did a speech to noise test on me and I'm a non-native speaker of English, I probably would do much worse than all of you who are native speakers of the language. So definitely there's going to be a difference over there. So you need to differentially diagnose and find out what is the problem that the person has and then work on it from that point of view. So I don't think it's just one continuum. Take, for instance, now ADHD versus APD. And they are totally different in the hyperactivity or attention. So if a person has more of an attention problem, it's more a psychological problem that you need to be dealing with, a behavioral problem or a psychiatric problem, giving more a pharmacological line of treatment. So the treatment procedure is going to be totally different. Now, if you have a person with an auditory processing problem, and all of my research shows that if you do give direct remediation, it works wonderfully. And just about 8 to 10 sessions, it makes a big difference. But now if a person has a problem because of a peripheral problem, it's not going to be treated so very easily. So there is a distinct difference. And so I will say it is not a continuum. They are different problems and you need to differentially diagnose them.
1 more minute.
Yeah, Dr. Wilson, go ahead, please.
Oh, just quickly, there could be great value in considering CAPD as a spectrum disorder. It might allow us to better consider the possible different causes, the possible heterogeneity of the disorder. It could allow us to take the CAPD construct into another area that would allow us to better consider those possibilities. It might also allow us to better consider CAPD not as being categorical, you have it or you don't, but it might allow us to give us a better sense of degree of CAPD, an ability to give it a rating on a scale. How much CAPD might you have? It might not be where CAPD would stay, but taking CAPD into a spectrum disorder construct could allow us greater flexibility to consider the possibilities of CAPD in a similar way that we saw with auditory neuropathy. It entered as a spectrum disorder. It's now exiting as being considered separate diagnosable disorders.
Great. Do we still have time, Max, for one more question? Or we don't know?
We could do one more quick question.
Yeah, and this question is by Dr. Dave Demonis to Dr. Vermiglio. That is, if at some point we can diagnostically reliably capture what Dr. Moore has described as reduced connectivity for speech coding, would his model of APD meet some of the criteria for a true construct that you discuss?
Yeah, that's a great question. So I need a lot more information on listening difficulty. What is that exactly? So I would go through the Sydenham-Gutentag criteria again with the listening difficulties. Does it have an unambiguous definition? Does it represent a homogeneous patient group? Does it facilitate, or does it represent a limitation for the patient, et cetera? If that's clearly described, we can find a reference standard. If we can find a reference standard, we can clearly know the diagnostic accuracy of our test or test battery for that specific disorder. So in that case, it could be qualified as a distinct clinical entity, but I would need more information on that, on the construct.
Now, would Dr. Moore want to weigh in on this and talk about the connectivity of each code?
Certainly. I don't want to present listening difficulty as any sort of construct or diagnosis. It is simply a self-report of somebody who has issues that appear to be of an auditory nature. And I think that we can work with that construct, as we've shown in our program that I mentioned, towards looking at what underlies that problem or that group of issues, moving completely away from the AAA guidelines or the past history of APD. And, I concluded in putting this program together like 8 years ago that the only way was to start again from basics. And the basics was to ask the patients or their caregivers, what is the problem? And as a result of that, and having done a really sensitive, thorough analysis of the entire auditory pathway, this is what we've found, that that almost everything that seems to be differentiating these people who have a problem is located up in the cortex. We have found small indications of subclinical hearing loss, specifically in the extended high frequency region, but they seem to be explicable by people who've had otitis media, which itself is, a very specific construct. I'm sure Andy would agree with that. And so if you take that out of the equation, then you're left essentially with cortical issues.
Perfect. Thank you, Dr. Moore.
All right. So now each side of the debate, one person from each side has about 1 minute to present their closing remarks.
Whoever. Dr. Moore and Dr. Yathiraj, you can decide among yourself. I mean, one person from each side versus Dr. Vermiglio and Dr. Wilson.
Shall I go?
Please.
Okay, so my closing remark would be that since I am for the motion, you need to screen for an auditory processing problem. So either you use a checklist, a screening test, or both, then diagnose the condition. And yes, look for specific processing deficits, because when you're making your diagnosis about APD, it is based on the different tests that are different processes that are being evaluated. And based on the processes that are defective or deviant, give them deficit-specific remediation. So the way to go for remediation is based on the tests and your diagnosis.
Great, thank you. Dr. Vermiglio and or Dr. Wilson? Dr. Wilson want to go? Or
Sure, I'll speak to the concluding remarks. So this has been a fantastic discussion. Thank you again to the organizers. I think it's been awesome. And as everybody can see, the concept of CAPD means a lot of different things to different people. So when you say this person has a CAPD, we're actually really not sure what that means until it's teased apart, until it's disambiguated after the diagnosis. So my argument is that does not offer clarity or intelligibility for diagnosis and intervention. I think we need to turn it on its head, where we start with disambiguation, determine the target disorders that we're interested in, clearly define them, and then go forward, find the reference standard test to find it, and then move to determining the diagnostic accuracy of our test. And that's going to settle the problem that the insurance companies have with the lack of evidence for the diagnostic efficiency of our CAPD tests.
Thank you. This has been great. I mean, I keep telling people, and we also realize that 1.5 hours or 1 hour is not enough for discussing APD for the last 4 decades of whatever has happened in the field. But obviously this gets the conversation going at least. So thank you for that.
So now I'm going to share the pre-debate poll results again, so we can see that we were relatively split between for, against, and undecided. And so now in a moment, we will launch the post-debate poll, and in true to the format of the Intelligence Squared debates, which this is modeled off of, we will see if either side swung more votes. Yeah. So I'm going to now launch the second poll. And please feel free to make your selections.
This is pretty cool, the poll thing.
All right, we're waiting on about 20 more people to vote. If you're undecided, please select undecided so we know we can move on.
Attendees, please vote. Seven more people we're waiting on. Please press that button.
Could I put the organizers out of their agony and concede defeat?
Okay, well, thank you. So it looks like we have swung towards team against. So I think that's where we stand, and we are grateful to all the panelists. So now I just want to say thank you to our moderator and our panelists for your phenomenal arguments in our first ever debate today. We're so grateful to have such knowledgeable and passionate people to present to this community. Events like this are extremely rare, but they should be more frequent. This kind of discourse will further not only our knowledge, but it also inspires inquiry. So I want to thank you for being pioneers in our quest to keep our research community vibrant. On that note, we are going to end the Zoom in a moment. I just wanted to share on behalf of the NYCDCS committee what we have upcoming in spring semester. We will be sending out messages to CSD department chairs in New York State. We're going back to our New York State roots, and we will be hosting a data blitz for doctoral students. And so this would be doctoral students that have any pilot data or research that is further along or want to maybe present some of their dissertation results. We will allow probably about 5 minutes per doctoral student presentation, and we will be sending out an application form sometime in January. I think that will conclude our session for today. If you had questions that weren't answered, and if the panelists are willing to stay on, we can remain on another minute just to answer any remaining questions. Other than that, everyone have a wonderful day. Thank you for attending and have a great weekend.
Thank you, everyone. Thank you, speakers. Thank you, Melissa.
Yeah, thank you, everybody.
Thank you, everyone.
Thank you.